after that tariff negotiation, when you are a GP registered there, because we used to register with REMS. Anyway, you couldn't be paid by medical aid without registering with REMS. So REMS had your address. They will send you the page on which new tariffs have changed. Just that page only. And you will remove it from the ad lever and put a new page. If you don't do so, you'll charge the old prices and you'll be cheated as a GP. So we used to do that. Now, what happened? That's the history I want to give. What happened? Why did we deviate from there? In 1994, the process was then amended through amendments to the Medical Schemes Act of 1967. REMS now negotiated guideline prices with provider organization. The guide prices refer to as recommended scale of benefits for medical practitioners, aim to assist medical schemes with embarking on their own price negotiations with providers. The then Medical Association of South Africa, MASA, which now is called SAMA, the South African Medical Association, we just swamped the words. During my time, we had this MASA, Medical Association of South Africa. Now we have got SAMA, or South African Medical Association. It's one and the same thing, just evolved after democracy. So it introduced doctors' billing manual, which competed with the REMS prices, with fees that exceeded the REMS guideline prices. Remember, REMS was representing medical schemes, and SAMA, or MASA rather, was representing doctors in practice. They set their own prices, which were different from those of REMS. Schemes decided to pay whatever amount they considered appropriate. That means under these different tariffs, one by doctors, one by medical schemes, the medical schemes decided, look, I'm going to pay whatever I believe is appropriate. Now the problem with that is that patients were left to pay the difference between the reimbursed amount and the price charged. This was last published in 2003. At the same time, the Hospital Association of South Africa, HASA, that represents private hospitals, received permission from the competition authorities to publish a benchmark guide for fees for medical services. In 2004, the Competition Commission found that there was a collusion in the way in which prices were agreed upon, and passed a ruling prohibiting any collective negotiation of prices. It's not on my speech what I'm going to say, but I think it's worth explaining why the Competition Commission acted in this manner. The medical schemes did not have experience in this negotiating table which Minister Dow has outlined. They didn't have the experience, so they sent the medical scheme administrators to negotiate on their behalf, because after all, they are administering them. You are aware that medical schemes have got administrators. Some of them, like the powerful medical schemes like Discovery, they've got their own Discovery administrators. The others, their Discovery is Med Scheme, etc., etc. Now, they are the ones who are sitting at the table. I'll tell you what the problem is with that. Medical schemes are not supposed to be profit-making entities. The profit is made by their administrators, not the medical aid. Now, if you say the administrator must go and negotiate for you, the administrators are paid per volume and per tariff. If the volume is R1 million and the administrators are paid 10%, 10% of R1 million and 10% of 2 million are different entities. So if I'm an administrator, I'll move it to 2 million. After all, I'm the negotiator. So what will happen is you'll just phone the doctors and tell them, look, set your tariffs at this level. When we negotiate, we'll accept them. That's what the Competition Commission picked up. That the negotiation was agreed even before they sat around the table, that, look, go and set your tariffs this way. Me, I'll just accept. because they know that when they accept. So it was a perverse incentive. And so the Competition Commission came in and say, oh, this can't go on any longer. So the Commission was of the view that fee guidelines, including the scale of benefits used by the Board of Healthcare Funders, which replaced REMS. The Board of Healthcare Funders is called BHF. It's an association of medical scheme. And the fee guidelines of Hospital Association of South Africa, HASA, and the South African Medical Aid Tariff Book, respectively, are fixing prices of medical aid reimbursement, hospitals, and doctors. Remember, I said earlier that now we had 3 tariffs. One by the Board of Healthcare Funders, which represent medical scheme. The other by Health Association of South Africa, HASA, which represent private hospital. And the other by South African Medical Association, SAMA, which was earlier MASA. They say all their tariffs are actually fixing medical aid reimbursement, hospitals, and doctors. So practitioners, according to Competition Commission, should set their own tariffs rather than use the centralized tariff setting processes where there's no real competitive process between scheme administrators and providers in the tariff setting process. As such, the Competition Commission believed that they were contravening the Competition Act and they were involved in an illegal process. The Competition Commission then averred that the effect of the guidelines is that the practitioners who are competitors and therefore are firms under the Act do not compete on price for their services. To the extent that they do, they use the guideline as a basis. This amounts to indirectly fixing a price, the Commission explained. The consequences of the ruling of the Competition Commission required that medical schemes and patients should negotiate tariffs with individual doctors and other healthcare providers. I'm sure you are aware that this was a practice that was next to impossible, given the obvious power and knowledge imbalance and gap between a patient and his doctor. You don't expect a patient to go to their doctor and very sick and start saying, I'm negotiating fees. They won't even have anywhere to start. So this was one mistake committed by the Competition Commission in trying to resolve this problem. That will go individually. So that never happened. I don't think any one of you, no matter how you are educated here, you will ever try something like that. Even me, as a doctor, I don't think I'll try it. Because if I go to my colleague and examines me and do MIR and say, Minister, you are growing, there's a growth in your brain. I need to take it out and I'll need 250,000 rand. On what basis do I argue with him? I don't even see what is in my head. How do I start saying, no, but doctor, you can't. It's simply not possible. Unfortunately, patients were given an impossible task because of these complexities. So this left a deep lacuna in tariff setting. That means after the Competition Commission made the ruling that there must be personal negotiations, which never happened, there was clearly a lacuna in the setting. To address the lacuna, in 2004, the National Health Reference Price List, which is called NHRPL, based on an agreed list of services and standardized coding environment, was established based on the Board of Healthcare Funders Tariff Guide, which was adjusted for Consumer Price Index. Medical schemes could use the NHRPL to calculate their own reimbursement levels based on the membership and affordability, usually a percentage of the NHRPL tariff. The set reimbursement levels, unfortunately, had no connection to the billed prices charged by providers, who continued to charge higher prices. This resulted in members being billed for the balance between the NHR LPL stroke reimbursement level and the billed prices. In the absence of penalties for exiting this NHRPL, the health provider groups were in a position of market power and faced no incentives to cap their fees. In December 2006, the National Department of Health published regulations relating to the process of determining the reference price list for comment in terms of section 90 subsection 1 subsection U and V of the National Health Act. And in July 2007, the minister promulgated these regulations. This was an attempt all the time to regulate the prices. Based on these regulations, the Director General of Health in 2008 invited for submissions from all stakeholders contemplated in section 90, subsection 1, subsection V of the National Health Act 2003. This regulation served to invite private hospitals, medical practitioners, and medical schemes to submit information regarding the cost of running health services. In other words, the department said, look, we can't allow this lacuna to go on. So in terms of the National Health Act, they invited the people in this scheme who used to sit and negotiate because they can no longer do so because the Competition Commission has abolished it. They said, look, please provide to the department the cost of running your health service. Then it will guide the department to set tariffs. How much do you spend when you see a patient and give treatment and all that? This is what the department asked for. Unfortunately, there were several disagreements with the submissions made by private healthcare sector. This related to the following. In other words, when the private sector was asked, show us how much we spend so that we know the cost of you seeing a patient. So when we said the tariffs, will know exactly how much. But when they submitted, there was serious disagreement. And this is where the disagreement was. Number one, they provided incorrect cost data. And this was identified during verification exercise, where a person or a practitioner just claims that I spend so much, and the data is wrong. In other words, they are providing information which will make the tariffs go higher, but the data is wrong. That's number one. Number two, there was disagreement regarding acceptable bed occupancy rate, because the amount of beds that are occupied in a private hospital also determine tariffs. The private hospital, they work more or less like the airlines, yeah, or hotels, you know. If you are in an airline and many seats are empty, the airline is going to run at their loss. So what they don't tend to do, if the bed occupancy rate is low, the patients who are there are going to pay more to cover for the beds that are not occupied. So if you stay alone in a ward in a private hospital, you must know you are paying for all the other beds. These are there. Nobody will tell you that. They'll just tell you your disease was very serious, so you're going to pay this, but basically you are paying for the other patients who are not there, who didn't come. So that was a second disagreement with the department. The third one was disagreement regarding property valuation, the replacement value. The healthcare provider, especially private hospital, they insisted that when they charge a patient, they must take into consideration the price of putting up the hospital. It must be paid for by the patient. In other words, if I build a huge hospital that cost me 20 million rand, patients will have to pay for that when I start seeing them. Now, that was not necessarily rejected. What was rejected is this. They insisted on a replacement value rather than a value of the initial cost. What do we mean by that? If I build a private hospital in 1990 and it cost me 10 million rand, and now it is 2025, it costs 50 million. I charge the patient on the basis of the 50 million, not the 10 million I spent when I built it, but the 50 million, which is its value now. And obviously, the department could not accept that under any conditions. It was clearly cheating, but they insisted on that. The other disagreement was providers unwilling to consent to a verification process. In other words, you said, give us your information. After we get it, we are going to verify. And they said, no, you're not going to do that in my practice. Private hospitals were unwilling to share detailed information regarding cost information because they will say this is private information, which if I disclose, my competitors will know and they will beat me. So they hide behind that. So they were not willing to share the detailed information regarding cost. Then the last issue was the non-representative sample size in the cost survey. Now, these were the problems that the government was faced with at that present moment. So the information could not help. Now, because the government was insisting on going on with verification processes, etc., HASA, SAMA, and other who were against the reference price list in 2009 went to court. The North Gauteng Division of the High Court, on the 28th of July 2010, ruled that the underlying regulations set up by the department for determining the reference price list were found to be invalid due to the absence of consultation between the Minister of Health and the National Health Council. Maybe I need to explain this. We have got a structure in the statute called National Health Council. This is where the minister, the 9 MECs meet quite regularly. It happens in every department, and they call it a MINMEC. MINMECs are generally a coordinating structure, but in health, they are not. They are a statutory structure. And the reason being that unlike all the other departments, in health, it's not only the minister and the 9 MECs which meet. There is also the Surgeon General of the South African Military Health Services, because they provide health care, even though to the army, but sometimes to the army and their relatives. So they do provide health care. But some clinics, especially in metros, as you know, are run by municipalities. So SALGA has got a seat. So it's 4 entities, all levels of government, including South African Military Health Service, they sit. That structure is called NHC, National Health Council. So the judge ruled that these proposed tariffs the minister was setting, they did not go through that council, so they were regarded as invalid. In other words, the case against the state in setting regulated tariffs was won on the basis of procedural technicality, but not on the substance or merit of it. The judge was not saying it's wrong for the government to do what it's doing. It said, but the procedure in terms of law was to have gone to the National Health Council. And I can confirm to you today that once bitten, twice shy. For these regulations from market health inquiry, for us to bring them in front of you today, we had a National Health Council on the 28th and 29th November, where we took the National Health Council through them, and they were adopted there because we have learned our lesson. The Health Professions Council also attempted, as you know, the Health Professions Council of South Africa, which registers doctors and other health workers, also attempted to regulate tariffs of practitioners because they were saying it's immoral and unethical for the health sector just to charge whatever they want. So they try to say, on the ethical grounds, let's try to control this. The HPSA is empowered in terms of Section 53, subsection 3, subsection D of the Health Professions Act to determine and publish normative fees. In 2012, HPSA attempted to issue guideline tariffs for the determination of fee norms by the Medical Aid and Dental Professional Board using the Council of Medical Schemes National Health Reference Price List 2006 rates, inflated by 46.66%. Various stakeholders objected to the proposal, alleging that they had not been consulted and that the basis on which the prices were decided was arbitrary, flawed, and possibly anti-competitive. The South African Private Practitioners Forum, which represents specialists, threatened to take the Health Professions Council to court. And I don't think this was a threat, because they have taken us to court now about NHI, the same South African Private Practitioners Forum. So the issue of threatening court cases, that doesn't start now with NHI. It has been there even before on tariff setting. The Minister of Health then appointed a task team from the Council of Medical Schemes, the Health Professions Council of South Africa, the National Department of Health itself, and legal experts to develop a framework for negotiations of tariffs in the private health sector. The task team